Hey, good morning. This is Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dulce Simons Family Studio on yet another cloudy, rainy spring morning here in now June the 1st, and delighted to be back with you today. We are in the middle of a big flippin' deal here in our studio because our team here, I've already called them my Star Trek reference, of course. I feel it's like I'm on the deck of the Enterprise. I'm actually in the engine room, and I've got Jordy LaForge and Montgomery Scott. They have flipped this place. They look like they're in front of the engine room down there on the Enterprise, and man, these guys have worked hard to change our studio around. This is a cool place, folks. This is the place to be. It's not at the K, it's not on Arrowhead, it's here at the Dulce Simons Family Studio because of the hard work this team has done.
Thank you, Captain Stites.
Yeah, I think I'm more like Ensign Stites, you know, one of those red shirts who can get knocked off from time to time. So joining us in the studio today is Dr. Jeff Burns, a co-director of the KU Alzheimer's Disease Center. He's got big news on the horizon for brain health. Looking so forward to hearing about that. But first, Hawkeye.
Yeah.
We continue to do well and to continue to cruise at a low altitude. I like it.
Very happy about the numbers. 2 active infections, 1 in the ICU, but none on the ventilator, and 8 additional meeting that recovery time frame after that 10 days or whatever since their diagnosis or their symptom onset. So a total of 10 patients, but again, 2 active with only 1 in the ICU and none on the ventilator. So that's very good right now.
You know, I think you and I could become yesterday's news the rate we're going.
You know, hopefully.
I think that's a good thing. What do you think?
I think it's better to go back to maybe the way things were in 2019 than they were in 2020.
I like it. And if you think, we have been at this for a couple of weeks now with kind of more going back to the restaurants and taking masks off and stuff like that. 2 active infections. That's crazy good. What does that tell us, Hawk?
Vaccination works. Continue
Yes.
to vaccinate. You know, anybody from 12 and older, please get vaccinated because we are showing that it does work overall, the numbers. And we've seen that around the country as well. A very significant drop in the rolling 7-day average of cases around the United States. And Hayes should just mention as well, they have 2 active patients as well.
And we should take note that there was a study you and I had the privilege to look at over the weekend, I think, looking at an antibody levels, the prevalence of SARS-CoV-2 antibody levels in patients who and had been measured. And there are thousands and thousands of patients from every single state across the country. It looked like the rate of antibody positivity was between 10 and 40% by state across all age groups, and that the overall average was probably around 20-25%, suggesting that if you take 50% of Americans who have gotten 1 vaccination, and really 20 to 25% of people who now have been infected, again, I think that data looks pretty good. A lot of good testing being done on this antibody study. That suggests that 70 to 75% of Americans have either had COVID or had at least 1 shot.
Yeah.
That looks pretty good. That's a ton of people.
Yeah, it is a lot, and hopefully we can get to that more of that population immunity or something where we can continue to drive down the numbers of those that get significantly ill. And also, you know, one of those age groups that was pointed out to us was that younger age group. So getting those teenagers vaccinated up to their 20s, getting those that subpopulation vaccinated is going to be very important because they had a large amount of seroprevalence as well.
And 18 to 25-year-old age group, 20-25% of folks have had it too. So I think, you know, even in the lower age group, there's a younger age group beyond that. And I think what it really tells us is there is just a whole lot of COVID that has already been communicated when we knew we had widespread community infections going on. And so if a 20 or even a quarter of our population has already had COVID-19 and 50% of folks have been vaccinated, now some of those people are going to be in both categories, but that just means, like I said, we've had 60-70% of people that have had either the vaccination or had COVID. I think that's what's driving our numbers down. Right?
You know, I believe it is, but you know, we should also state that we do believe, based on the nature of normal cough and cold coronaviruses, and we know that you can be reinfected with those in a few months. I think it's still important that right now the best data signals is that you have even better immunity with vaccination as compared to natural immunity.
And some emerging information coming out of the UK also that on the single shot regimen, whether or not it's as effective as the 2-shot regimen against the variant in India. Have you heard about that?
Not yet. No.
Yeah, I heard that. It was on that New England Journal podcast. I was listening to it today, so something we'll want to keep an eye on, the necessity of a 2-shot regimen. Jeff Burns. I hear there's no reporters on the line, so I'm going to segue right over to you.
Great.
Good morning. Welcome into our studio.
Thank you.
It's a pleasure to have you here today,
Great
sir.
to be here.
For those of you who don't know, Jeff Burns is like one of the leading scientists throughout the United States in Alzheimer's disease research and has been a real founder of some of the importance of exercise and other things around Alzheimer's disease. Jeff has really helped spearhead our effort and is also just one of the finest human beings you'll ever meet. But I think he also has a lot of kids, which means my brain would be completely scrambled if I were you.
Yep.
Is that a danger for you, sir?
Is what? Scrambled brain? Or?
Yes, scrambled brain with a lot of kids.
Oh, that happens. Yeah.
How many
I
kids do
feel
you
that.
have?
10 kids.
Well, that's a
No
lot.
way.
Yeah.
What are the
Yeah.
age
That he
range?
knows of.
They range from 21 down to 8.
All right.
So yeah, there's
Wow.
a lot of scrambled.
It is a lot
in
of
there.
scrambling just to keep
Yeah.
up, but you can field your own starting offensive football team. I'm ready to go.
Keeps you young,
Two basketball
keeps you young.
teams.
Yeah.
Yeah, we do that occasionally.
So what has been the impact of COVID-19 on Alzheimer's disease patients and their families, Dr. Burns?
Yeah, well, I mean, it's had a big impact. I mean, we know, that this COVID-19's really hit the nursing home population. So obviously, it's had an impact on patients, Alzheimer's patients in nursing homes. So I mean, one of the facts is 30 to 40% of the people who've died from COVID-19 are in nursing home populations, and Alzheimer's patients are a predominant, part of that population. And so, the Alzheimer's population's taken a big hit from COVID-19 in terms of deaths, but probably a bigger impact that we maybe didn't think about a year ago is on caregivers. So caregivers who are, working hard, working overtime all the time, who suddenly don't have the support and the emotional support from their families and the connection with others. And that's taken a big toll. That's something we've been dealing with for the last year with our support groups and our moving online. We moved a lot of stuff effectively online, and people, caregivers also migrated online, and that allowed us to really reach them. But I could say our social workers have been working overtime, trying to help out people in need, in crisis. And so, yeah, COVID-19 really has had a big impact, both direct and indirect, on patients with Alzheimer's.
Yeah, so that's such a big deal, and I think we can't measure that. Just the isolation probably made people with Alzheimer's even have a more difficult time.
Yeah, and actually there's some evidence that that sort of social isolation for the Alzheimer's patient can drive, decline, drive greater and faster decline. So there's indirect effects on the Alzheimer's patients themselves and on the caregiver, who plays such an important role.
Gosh, that's got to be so true, because Alzheimer's, I think, is isolating enough by itself for both the patient and the caregiver, but then to have it so you really shouldn't even leave the home and then stay at home all the time. I think that's going to be really hard on both the caregiver and the patient.
That's it. That's exactly it. That's where the struggle's been. Is I think every caregiver, I think, on some level feels isolated and feels sort of cut off. They're working hard. People don't know what they're doing and how hard they're working to keep things together. And then this on top of that, cutting them off from family, or not being able to hire help to come into the house to help them. Those kinds of issues really magnified, sort of the difficult job of a caregiver, and then had an impact on the patients.
So could there be new hope on the horizon? Because I know sometime around June the 7th, the FDA could be set to approve the first new Alzheimer's drug in 19 years. Tell us a little bit about how that drug works. What could it mean for patients?
Yeah. So, yes, next Monday is a big day that we've been waiting for a long time, and that's the day when the FDA is set to rule on whether or not to approve this new study drug, Aducanumab, from the company Biogen. We haven't had a new drug in 18, 19 years, and so this is a big day for us. We've been preparing for it, and we've actually been a part of the studies testing this drug. And so to have, so basically it's a new day for us to have this possibility of a new drug that actually might might slow the changes in the brain that are associated with Alzheimer's disease. So it's a big day, but the chances that the FDA will approve it, it's certainly not 100%. I put it probably at 30% that the FDA will approve it. That's sort of my best guess, but we'll see. And if it does get approved, it's going to really change the game in terms of how we diagnose Alzheimer's and how we treat Alzheimer's.
So tell us a little bit. You have a 30% chance that it'll be approved?
Yeah, I put it at 30%, and the reason why is the data isn't slam dunk data.
So talk to us a little bit about the data. Then, what is the drug? What is the impact it has on Alzheimer's? And tell me about your relative optimism. And yet, you are relative pessimism, but you're always an optimistic guy. So tell me about how that's working in your mind.
Okay. Well, so what the drug does is it's an antibody against amyloid. And amyloid is something that we see build up in the brain of somebody with Alzheimer's disease. And what this antibody does is crosses into the brain, sticks to the amyloid, and then the immune system pulls the amyloid out of the brain. And what we've found is it's safe with the potential for side effects, but relatively safe with potential for some side effects that we have to keep a close eye on. But there's 2 major studies that have been done on it, and one study showed it slowed decline in Alzheimer's, but the other didn't. So 2 major studies, one showing effectiveness and one not. Biogen believes they can explain why the second study didn't show benefits, but what happens in this process of approval is the FDA reviews it, a team of experts review it, and those experts are folks like myself in the field, or not in the field, actually are clinical trial experts, reviewed the data and basically voted 8-1 against approval. Now that's just one part of the FDA approval process, but when the experts vote against it, the FDA usually follows, but not always. And so that's why I believe there's still a chance it'll get approved, but when the experts came out sort of against this, it reduced the chances quite a bit.
Mm-hmm. Well, that's a disappointment if the 8-1 voted against that. What do you think would prompt the FDA then to go ahead and think, well, maybe we should still approve it?
Yeah, so I mean, it's do you believe, this one study showed slowing, do we believe that? And do we believe sort of this explanation for the second study, why did it not show the same sort of benefits? And there's reasons that Biogen believes drove that, less of an effect.
And what are those reasons?
Things like lower doses were used on average in that group, and that study was a little bit earlier, and because it came in a little bit earlier, there was a little more concern about side effects and using lower doses, and not as many people received the full dose over time. And so when they cut the data down and throw out the folks who didn't get the higher dose, they believe there's an effect from this drug. But it's what's called post hoc analyses, which can get a little messy and you can see a lot in data if you really slice it and dice it. And so a lot of skeptics out there are saying that they're slicing and dicing the data. We need a whole nother study, which would take years, and that may be the right way to go. On the other hand, if they approve it and we follow over time and collect more data and really prove over time that it's effective, I could see the FDA saying, it's been 18, 19 years. There is maybe enough data here if they believe it, and maybe they'll approve it sort of as a starting point, so that we can, get going with these types of drugs that we believe may modify the disease process. What we have right now is drugs that help the symptoms. What we've been working on for the last decade or two really is drugs that impact the disease itself, the changes we see in the brain. We don't have drugs that do that right now, and so this would be a new sort of as I said earlier, a new day in fighting Alzheimer's disease. It would really give us a whole other tool, but it would also increase how much increase patient volume. It would increase the number of scans we're getting. We have to or lumbar punctures to make this diagnosis and identify who has amyloid and who doesn't. And then we'd have to follow people over time to look for those potential side effects.
So why does it stop you from having to do the more invasive procedures to make the diagnosis?
Well, so there's, in diagnosing patients who are, we'll see what the FDA rules, but if we, to prescribe this drug, at least in trial, as we've been doing for the last 6-7 years, we need to make a clinical diagnosis. Do they have cognitive changes? Do they have measurable impairments on, cognitive tests? And then we need to see, do they have amyloid in their brain? And there's 2 ways to do that. We can do it through a PET scan, a real fancy, expensive PET scan, or we can do it through a lumbar puncture where we assess for amyloid in the cerebrospinal fluid. It's a pretty simple procedure and safe procedure, but it's invasive, and there's a lot of fear around that. And so 2 ways to do it, pros and cons to each one. And but those are going to be required. Now, the good news, though, on the horizon there's blood markers for amyloid. We think in the next 1 to 2 years we're going to have simple blood tests that will tell us or give us sort of a probability of does somebody have amyloid in their brain or not. And you could see this sort of evolving to where we in the clinic can test somebody and draw blood and know whether or not this drug focused on amyloid could be something we prescribe. And June 7th will tell us a lot about whether that's sort of the vision for the future or not.
Well, it's funny because, we think about the vaccination. We did early use authorization because we had this terribly deadly disease. Alzheimer affects thousands of people every day, and yet there's only one other drug for it. So do you think we could even consider an early use authorization, you say, and continue to collect information that allows us to analyze it as we go through?
Right, and I think that's the approach the FDA may take. This is new to me, this whole FDA thing, because as I said, it's been 18, 19 years. Actually, since I've been in the field, one drug's come along, and that was my first year in the field.
You look like you're probably an intern that year, maybe still
I
a
was
student.
a fellow, first year fellow. And so this FDA process, what are the limitations they can put on it? I think if it's approved, they're going to put some limitations on it. They're going to want a lot of data collection to be testing, the safety and the efficacy of the drug. I think that's a good analogy that there will be some limits placed on it the way these vaccines have been approved and moved into the world and then tested and then used. And I'm hopeful. I'm skeptical. Amyloid is something that's a part of Alzheimer's disease, but people argue, does it cause the disease or is it sort of the byproduct of the disease? And we're more on the side, our center is more on the side of it's the byproduct. It's the smoke, not the fire. And so if we pull the smoke out, it may help a little bit, but it's not going to cure the disease. The fire's still going on. Yeah. And that's what we believe. However, if this data is correct, and then we want to use it, it's not a cure. It doesn't look, the early data doesn't support the idea that this is a cure for Alzheimer's, but it does, support the argument that it slows the disease progression. And so we'll use it, although there's a lot of folks, out there, a lot of skeptics out there saying, they're an expert in the field and they're not going to use it. And so it's going to be an interesting time, whether they approve it or not. And I'll just say one other thing. I think this is a sign of a whole new time for Alzheimer's disease. It's been a long time since we've had a drug up for review. We have it now, but I think it's a sign of a lot more to come. And I say that because we've got way more diversity in terms of testing drug targets than ever before. 10 years ago, it would have been one thing, probably amyloid, 1 or 2 things maybe. Now we've got a list of 10 different mechanisms of action that we're going after to try to treat Alzheimer's disease, and there's just more diversity and creativity and innovation in terms of fighting Alzheimer's. And so, amyloid drugs may be a part of our future. There's other drugs that are candidates that are being tested, but there's a number of other things, and I think the day's coming where we're going to attack this disease from a lot of different angles and understand it from a lot of different angles. I think there's a lot of ways to get to dementia and to get to Alzheimer's. It's not just one, and it's going to take a broad approach to treat it effectively. And that day, I think this is a sign of that day coming.
Yeah, I remember having been in CF world for so many years that when you finally get some drugs, you're just so happy about it, even if the improvement is just a little.
Right.
But it is a sign. And then if you more, and then a few more, and 30-year journey. But all of a sudden, CF is a treatable disease, and for 80 to 90% of patients with CF now, and so that's a pretty remarkable statement. And God willing, let's hope that we're going that direction with Alzheimer's. You're about to say.
If I could just interject a minute. Do you know how many people were in those studies for that drug off the top of your head, just around?
A couple thousand.
So a couple thousand. Yeah. So I think when you put that in the context of COVID-19, where you said we know that Alzheimer's is devastating for the patients and their families, and how long has it taken for this drug to come to market, or these studies on a couple thousand people, and you're looking for approval, when we have at least 70,000 for the mRNA vaccines tested, done expeditiously, but in the right manner, looking for safety and efficacy signals, and we have overwhelming data about those things. But that is surprising given still the hesitancy of people wanting to get the vaccine. Just as you have mentioned before, most trials deal with smaller numbers of people because of the resources and the cost that it takes to do those. When we have this expedited process, looking at all of those those data signals showing safety and efficacy of these vaccines, and just how well and how expeditiously they've been brought to market, I think that's important to understand this Alzheimer's drug in the context of the COVID-19 vaccines and what they do to help. And hopefully those things can continue. We know that the people that are looking at safety and efficacy are doing so every day. Again, to promote that process.
So, well, good luck. Let's hope this works. Anyway, is this going to work in systemic amyloid at all, this drug?
That's a good question.
I wonder if that'll help there, huh?
No, yeah.
Yeah, it'd be interesting.
Yeah.
Well, let's see what good questions are out there, Jill, 'cause I bet there are a bunch.
Yeah, Maggie wants to know, if it's not the protein, then what helps slow the progression of Alzheimer's?
Well, right now, so what helps slow the progression of Alzheimer's? Right now, we don't have drugs that really slow that disease process. We do have a couple drugs that can help with the symptoms. They help treat the symptoms, but nothing slows the shrinkage of the brain and the accumulation of these abnormal proteins. So we don't have anything yet, but we're working on a bunch of things. So, the other question was, what are the other targets? And so we're going after, the tangles in the brain that are not amyloid plaques, but there's also tangles building up in the brain. We're trying to block those from building up. We're targeting metabolism and energetics of the cells. So inflammation, a number of different targets like that, where we're now attacking them, going after them. So it's a broad spectrum of things that we're thinking about, the synapses and the health of the synapses. So it's a whole new world in terms of research and sort of therapeutics development than it was 10 years ago.
What a big deal. And what an exciting time for y'all.
Yeah.
And Jenny wants to know, how do you tell the difference between dementia and Alzheimer's, and what is the prevalence of Alzheimer's in the population?
Okay, so great question. Yeah, so that's the number one question I get is, what's the difference between dementia and Alzheimer's? And dementia is a broad term that just means memory and thinking changes that interfere with daily function. Lots of things can cause it. Number one cause is Alzheimer's. So Alzheimer's is a specific cause, a subset of dementia, but it's 70% of dementia. And it's defined as amyloid plaques and tangles in the brain. There's other things that can cause it, like dementia with Lewy bodies, strokes, and other rare things that we look for, frontotemporal dementia. So Alzheimer's is a cause of dementia. And then the second part of the question, I've already
What
forgot.
is the prevalence?
Prevalence,
How much?
It's incredibly common, way too common. 1 in 10 or so over the age of 65 have Alzheimer's, which is a pretty amazing number, 1 in 10 over the age of 65, but it's 1 in 3 over the age of 85. And that's the fastest growing segment of the population. So that's why we're seeing this big increase.
Any thought about why it's like that? Why is it 1 in 3 over age 85? What about aging is causing, because clearly it's related to aging, so what about aging is causing that?
Well, that's the big question. And that's what, aging is the number one risk factor. So there's something about aging and the aging process. We think it has something to do with the cellular metabolism and energetics, but others think it's over time we see a buildup of these abnormal proteins, and the abnormal like amyloid and tau, tangles, and those drive, a cellular response and a cascade of problems that sort of spiral into brain cell death and gradual decline. So, but that's the big question. If we can understand that, and somebody like Russ Swerdlow here, he's working on mitochondria and metabolism at the cellular level, and trying to understand how does aging, create this risk? How does aging drive these changes and put somebody at such high risk? Because yes, clearly this is an age-related disease, and age is the primary factor. So understanding how do cells age and what puts people at that higher risk is so important.
Sherry, and I'm going to say this drug wrong. If it's a drug, it might be a supplement. I don't know. But Sherry says, I was told memetine shows the decline. Is that not the case? And it's spelled MEMANTINE.
Mementine. Yeah, so there's two types of drugs that we use to slow the symptoms. So it slows the symptomatic, and one of them is mementine, or Namenda is their brand name, and the other is a class called cholinesterase inhibitors, and Aricept or donepezil is the most commonly used one. It's been around for 30, 40 years. So we use those two to go after, the symptoms of Alzheimer's. They slow the symptoms. There's a nuance here. They improve the cognitive testing over time on average for somebody, not necessarily improve compared to somebody who's not treated. So there might be stability for the group treated, whereas the untreated group tends to decline. And that's the symptoms, the cognitive symptoms. What's happening in the brain isn't impacted by those drugs. So we see, continued shrinkage of the brain. We see the continued buildup of these plaques and tangles. And the drugs we're working on now, we're trying to modify that disease process more so and by virtue of doing that, improve those cognitive symptoms. But today we consider, we have effective, modestly effective drugs to treat the symptoms, but what we want are effective drugs that modify the disease process and slow that decline.
And so is it fair to say then that that's one part of the story? You mentioned that before. There's going to be a lot of chapters in the book that try and beat Alzheimer's, and that's one chapter in the book, is the slowing of the cognitive decline. But why would your other physical symptoms continue to progress, but your cognitive decline slow with those drugs?
Yeah, so with those drugs, what we see in Alzheimer's is some of the neurotransmitters are reduced. And if we can sort of boost those neurotransmitters, we can see a symptomatic benefit without really modifying that cell death that's occurring. And so we're seeing basically, so you drink a cup of coffee, you're symptomatically a little bit better, maybe at cognitive testing. It's that type of cognitive benefit that we tend to see in patients with Alzheimer's on these drugs. Although we see it over time, and we don't see a big boost, we don't see a big jump in cognition, but over time we see a little less decline in cognition, and it's because those drugs are working to sort of replace things that are missing, as opposed to fix anything or interfere with that sort of that progression of the disease in the brain.
Jill, other questions?
Oh, yeah. Jean, Bob, and Ann want to know, what about exercise? And they're asking questions about diet, too.
Oh, yeah.
And mid-chain triglyceride.
Medium chain triglycerides.
So this is something you specialize in terms of research around Alzheimer's with exercise.
Yeah. So thanks for the question. But yeah, we think lifestyle is important, very important. We know it's important. And we're trying to really prove it and better understand how we can use diet and exercise and sleep and stress reduction and all these things that we know are good for us, but how do they really impact the brain? And we do believe that exercise is good for the brain, and we've got ongoing studies, small and very large, that are really trying to definitively understand how does exercise impact the brain, and can it reduce somebody's risk long term. Diet, in the same manner, we've got studies where we're trying to understand how does diet impact the brain, and put somebody at lower risk. And we preach, so on the science side, we're trying to really prove it and understand it better. On the clinic side, we preach it. We tell people, get out and walk every day, eat a healthy diet, and the way the definition of a healthy diet evolves over time. Think back 30, 40 years ago, it's different than what we're saying today, but we believe the most data exists for a Mediterranean diet pattern. That's a diet pattern with a lot of fruits and vegetables and fish and not a lot of meat and potatoes, but and a lot of olive oil, healthy fats, avocado, olive oil, and so Mediterranean diet pattern. It's not a restrictive diet too, but to sort of shift your pattern more to that. And so we're trying to understand that better. But meanwhile, we think those are things you can do to really take charge on some level. They're not a cure, but we think they may push. If somebody's destined for Alzheimer's, it may push it back a few years if you do everything right. That may not sound like a lot, but a few years can be a lot for people. But across the population, if we do that, if we push the sort of the average age of onset back 5 years, we'll cut the prevalence in half. And so we can have a huge impact from a public health perspective if we capitalize on these.
Well, I'd say a 5-year pushback of a disease onset is remarkable. Actually, that's really strong evidence of the importance of that.
Yeah.
Yeah. We got to make sure we get that out there.
And just to clarify, is daily exercise like Jill Chadwick walking exercise or Dr. Dana Hawkinson tearing it up in the gym?
Oh, excuse me. What about Dr. Stites?
Okay.
I was on my spin bike for 30 minutes this morning. I was doing a high intensity interval training.
Okay.
Morning
Well,
workouts,
okay,
yeah.
where is it?
Morning
Is
out.
it Chadwick,
Morning
Stites, or Hawkinson?
Well, it's individualized, and that's actually something we've studied. It's what's the right amount? What's the right type? We've got a big study we're gearing up for is what's the right type? Do you need to lift weights? And if you lift weights and do the aerobic, does that have a bigger impact? And the answer is really you need to push your heart and lungs, and gain something. So we find that if people's heart and lung function gets stronger, we see brain benefits. And for some people, it doesn't take a whole lot to push their heart and lung function. If you're going from nothing, sedentary activity, to something, there's a big bang for your buck. If you're somebody who's already fit and you really if you can further boost your cardiorespiratory fitness or your heart and lung function, we think there's some benefit there to the brain. And so it's individualized, and something like intensity matters, duration matters. But if for somebody who's sedentary, just getting out and walking 10 to 15 minutes a day is probably enough. We've done a study where just 15 minutes a day, 5 days a week, or 75 minutes a week showed a little bit of a boost, but more was better. So I tell people just get out 10 minutes, 15 minutes a day, and it's just walk for walking's sake, and that can have an impact. But if you've been doing that for a long time, then you need to sort of boost the intensity a bit to try to improve your heart and lung function.
So let's just say this is interesting because what you really are saying, if you have a healthy heart, healthy lungs, which probably means you're healthy in other places, you're going to have a healthy brain. It all kind of does tie together, ultimately, which we all know in as physicians. I think you would say people don't get as sick from name the disease if they're healthier. I would certainly say that if you have better lungs and you're able to do more, you're going to have a better life because you're going to be able to just be more comfortable, you're going to be able to do things as you get older. You're going to say you're going to be able to think better. So it really is healthy life equals a healthy life.
Yeah, it all connects, and it's the same sort of common sense stuff we hear. We're studying that. Eat right, exercise. It's good for your heart. It's good for your lungs. It's good for your brain. And we're really trying to prove that all these things are
I think it's good for your
interconnected.
soul, too.
Yeah,
We
and we
know
see
it's
that
good
in
for
some
the
of
soul.
our other colleagues. Our cancer oncologist doctors, our transplant doctors, they always look at functional status in general, and that's the overall, how do you function on a day-to-day basis? And
We
what
tell our
is your-
CF patients out all the
Yeah.
time, listen, if you exercise, you're going to do the best form of airway clearance to get mucus out of your lung is to exercise on a regular basis. I was at a dinner one time with a bunch of CF docs, and we're all kind of nerdy people. And that includes Dr. Salate. I don't know if you're listening this morning. But we were sitting around a table, we were all talking, what's the best form of airway clearance? Because we have entertaining things to talk about. We're a bunch of lung doctors. We're sitting around a table, we all said, exercise is the best form of airway clearance. I bet if you sit around a bunch of cardiologists, what's the best way to reduce your risk of having a heart attack? That's exercise. And you're going to say the best way to reduce the risk of Alzheimer's is?
Exercise.
So if we exercise and we're healthier, we do better. What a
Yep.
shocker.
Shocker.
Shocker. All right.
And drink water. So Sherry wants to know, does the brain shrink with dementia or just with Alzheimer's?
Well, okay.
No, that's a good question.
Yeah. So the brain shrinks with age. Beginning in the mid to late 30s, your brain starts to shrink, and it's kind of your muscles also. So we know we're not as sharp and as fast and as strong as we were at our peak as we get older. And the brain, we actually can measure brain changes of shrinkage just with age alone. It's a very small amount, but it's there. And what happens with Alzheimer's is we see sort of acceleration of that shrinkage. So we see a doubling of the rate of shrinkage in Alzheimer's. And then dementia depends on what's the cause. If it's Alzheimer's, it may, and actually there's other forms of dementia I mentioned, where we see maybe a whole lot of shrinkage in certain areas of the brain, and we look for those clues when we're diagnosing. But some parts of the brain shrink rapidly from other forms of dementia, like frontotemporal dementia, or some new diseases that were or newly defined diseases, like the late LATE, where we see a whole lot of shrinkage in the hippocampal region. The short-term memory region, so which we also see in Alzheimer's. So it's kind of non-specific finding to see that looking for that brain shrinkage, and meaning it can be caused by a lot of different things, but it's a clue for us sometimes for helping make a diagnosis of what type of dementia is driving that, cognitive change.
And Betsy says a lot of drug companies, or supplement companies rather, continue to market products to improve memory. She thinks that they're probably all snake oil, but she wants to know, is there any supplements that you would recommend?
So the short answer is no, not yet. And I don't take anything, and I don't recommend it. And there is a lot of marketing there, and there's a lot of money to be made, and people are making it. But the studies haven't really been done to definitively show that certain supplements have an impact, both, and we think of both prevention but also treatment. People who have memory problems, do we give them supplements? And not yet.
So are you on a Middle Eastern diet?
The Mediterranean diet?
Yeah, Mediterranean,
I try.
Yeah.
I try. We started talking about my kids, and so do I have full control over my diet? Kind
It's kind of hard to work sometimes.
So I try. I do my best. Yeah, but and the whole diet, and we're going to run out of time here, but diet, the medium chain triglycerides, there's some interest there for ketogenic diets. So sometimes I play with the ketogenic diet.
Yeah, we looked at this in CF a few years ago. It was the hot thing. It reduces the amount of infection, improves your oxidant ability, blah, 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 and then, yeah, it didn't do anything.
So we're actually studying it.
Well, good luck. I hope it does better for
Alzheimer's.
you all than it did for us. So.
Yeah.
All right.
And I know you have clinic this morning, but we do have some COVID questions, so I'm just going to kind of lump them together. Megan wants to know, there was a group of people at an outdoor festival at Liberty Memorial, about 30,000 people. She wants to know, are you worried about super spreader events from Memorial? And other people are wanting to know, how long do you wait to get vaccinated if you've tested positive for COVID?
You bet. Super spreader events, outdoors, Liberty Memorial. I think the evidence is pretty darn clear. Outdoor events look pretty safe, Hawk.
Yeah, I mean, hopefully a large proportion of those attendees were vaccinated, less than natural immunity, but hopefully they were vaccinated. In addition, I saw some pictures. A lot of people were fairly spread out. I think it's less of an issue compared to something that's indoors where you're having a lot of people.
Yeah.
And then
in the Royals games, and we know people have been back in the stadium.
Yeah.
There's been 7,000 and 18,000. Now it's full capacity.
Yep.
And whether it's in the United States or here or throughout the U.S., we're really not seeing those as super spreader events. I'm going to bet the Liberty Memorial is not.
Yeah, I would agree with that. And then the second question was?
If I have
Testing
COVID, do I wait till my symptoms are over, or do I?
No, again, the guidance is no minimum time between infection and vaccination. So if you're out of that 10-day period where you have to be isolated so that you're not out spreading it, wait till that 10-day period is over, and then you can go ahead and get vaccinated.
Cindy wants to know, are other hospitals seeing the same kind of trend that we are in terms of inpatient?
Yeah, we don't know that because we haven't had our CMO call this week, or there's one later in the week, so we'll be able to update you then. But right now, last week, they had not seen the same trend. As some had bumped up, but I haven't visited with anybody since last week. We'll work on finding that out and get back with you.
Isaac said, did you see that Moderna just applied for full FDA approval?
Yeah, that's exciting. That's going to give us, Hawk, another drug because I think Pfizer's going to get approved. Moderna's going to get approved. And then I think the other question out there is, will J&J end up being 2 shots, which I think we heard it here in July.
Yeah, hopefully we'll get to know. I think all of this is going to help because we know vaccination works, and we've seen that in our health system. So.
All
One
right.
more?
One more.
Okay, Phil wants to know, is anyone tracking this and where he can find it? His questions are, what percentage of fully vaccinated persons have contracted the disease, and what percentage of persons who have survived COVID but are not vaccinated have become reinfected?
Yeah, we don't know that data on the
No.
second question, really. what we know in the first one is it's the point of the vaccinations isn't that it does reduce your risk of contracting the disease. It reduces your risk of severe illness or death. And that we can say very safely, that's working. Where we're seeing patients who are coming into the hospital who have been vaccinated and who are COVID positive, they're asymptomatic. They're here for another reason, Hawk.
Yeah. Yeah, and I would really just kind of push people to that CDC website. They do have a section under their COVID area looking at reinfection. That really hasn't been updated now since vaccination has come about. They also have their statement on vaccination and reinfection. We know that a week ago, Morbidity and Mortality Report, which is one of the CDC publications, published a large report looking at infection after vaccination, so breakthrough infection. And basically what they said is it is a significantly smaller amount of people that are getting infected. And as of May 1st, they are not tracking just breakthrough infections anymore. They're only tracking those hospitalized infections because of the efficacy of the vaccines in just reducing the total amount of vaccination, of infection after vaccination. So overall, those numbers are small, and you can find those at the CDC website and at Morbidity and Mortality Weekly Report as well.
All right.
And Bridget and Angela have questions for Dr. Burns, but we will answer those in the thread.
Awesome.
I'll just get with you afterwards.
Well, we know, Dr. Burns, there will be a lot of people who have questions with you. So
Yeah.
we're going to have you back on our program because
Update
you
us on
are
June
the,
7th.
oh my gosh, we're going to need to talk to you soon. Hey, we will know more about June 7th about this story today after the FDA releases its findings. If you have questions about the Alzheimer's Disease Center, though, don't hesitate. Call 913-588-1227 or to go to kmc.edu/KUADC.html. Man, that's a lot of words right there, a lot of letters, but we will continue to follow this story closely. I think if you just Google KU Alzheimer's disease, you're going to get to that website. Tomorrow, our good friend, KCK Mayor and CEO of the Unified Government, the Honorable David Alvey, will be returning to the update to talk about progress in the city and Wyandotte County regarding the infection and vaccination rates, as well as the mask mandate that expired right before the holiday weekend on Midnight Friday. Lots to talk about. Bring your questions. Final thoughts.
Just looking forward to June 7th, seeing which way we go.
Yeah, no, that's going to be a big day for you. And I'm going to have my fingers crossed. I'm going to hope for you with early use authorization. Sometimes it's good to have something when right now you really have nothing or very
Exactly.
little.
Yep.
Yeah, I don't know what he said if our brain starts shrinking about it. At
Yeah.
30, mine's probably about the size of a walnut right
Yeah,
now.
watch
so.
out. Well, I have this big head at 7 5/8. I keep hoping that means something, but I'm afraid, based on what I said to my wife yesterday, and I got in trouble for that, I'm not sure it does.
Yeah, right.
Yeah.
I think, again, we are all happy with how vaccinations have gone. We saw the reduction in the overall disease spectrum and the number of hospitalized patients. Those events, such as the outdoor things that we saw at Liberty Memorial, I don't feel are as much of a problem or risk as something indoors. But the word is continue to get vaccinated. That is only going to help us moving forward. I think if people were able to get out, even though of the crummy weather this last weekend, if they were able to meet with friends, it probably seemed like a fun time. It probably seemed something more like 2019. The only way moving forward to continue to be able to do that is vaccination, so please continue to get vaccinated.
I just want to say thanks to everybody for tuning in. I want to say thank you to our team back here. You don't get to see them very often, but they did a great job. Logan and Anthony, Cliff, and others were here. They spent their Memorial Day weekend flipping the studio because we got a brand new equipment, and I think things are, I tell you right now, run so much more smoothly. And I want to say thank you to them for spending 35 to 40 hours here over the last 3 days making this place run so we can bring all that's important out here in the Medical News Network to you and to people like have Jeff Burns here, of course, Hawkeye, and thanks to Jill. So thanks to you all for listening, and remember, until we see you tomorrow, there's still no place like home.